Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Fractionated 90 Yttrium Ibrutinib Tayuxetan Radioimmunotherapy as an Initial Therapy of Follicular Lymphoma, an international phase 2 study in patients requiring treatment according to JELF-BNLI criteria by Tim Illich et al. My name is Antonio Pizzuto. I am Professor of Medicine at the Charité Medical School in Berlin, Germany, and I am head of the Department of Hematology, Oncology, and Tumor Immunology at the campus Benjamin Franklin of the Charité. My oncologic specialty is hematologic malignancies with particular focus on lymphoma. Chemoimmunotherapy has become the standard upfront treatment in follicular lymphoma, with several options to choose from. Likewise, radioimmunotherapy has widened our therapeutic repertoire, and several new drugs targeting intracellular pathways or with immunomodulating properties are showing promising results in early clinical trials. Having many different options to start treatment with is a welcome opportunity, yet poses a challenge for the hemato-oncologist in choosing the best treatment for an individual patient. In high-grade lymphomas, cure is a mandatory goal of first-line treatment, since it is a difficult task to salvage patients who relapse after chemoimmunotherapy. In contrast, follicular lymphoma recurrence lends itself to a wide range of treatment opportunities. Most patients are still likely to experience long-lasting remissions, and using intensive treatments, we can rescue even a good proportion of those patients with an aggressive disease course. Follicular lymphoma prognostic indices, such as FLIPI, although useful for stratifying patients in clinical protocols and for comparing results among studies, will not predict the outcome in individual patients. Since variation in age, general condition, comorbidity, and disease biology is very large, a therapeutic regimen that achieves the highest rate of complete remission and the best progression-free survival figures is not necessarily the best option for all individuals, bearing a risk of overtreatment for those frequent patients which may have excellent responses to a milder, less intensive treatment. Presently, most patients with follicular lymphoma undergo initial treatment with chemoimmunotherapy with a combination of bendamustine and rituximab, having substituted R-CHOP as a first choice in many countries. The side effects of chemotherapy are frequently underestimated in early reports of clinical trials, and the real impact on patients' health is frequently recognized only in retrospective studies that are specifically designed to compare the health states of age-matched individuals. So it is clear that anthracyclines and vinca alkaloids do have significant toxicities, which frequently become apparent only much later than the usual observation periods of clinical studies, or in conjunction with pre-existing or supervening diseases such as cardiovascular diseases, diabetes, and polyneuropathy. The better tolerability of bendamustine and rituximab as compared to R-CHOP, reported by the German STIL study, has been challenged by the results of the BRIGHT study in the USA. In addition, dedicated reports on late toxicity of bendamustine are not yet available. Radioimmunotherapy with CD20 radiolabeled antibodies has considerable activity in relapsed follicular lymphoma, and more so as an upfront treatment. A pivotal trial by Kaminsky and colleagues, published in 2005 in an unselected group of untreated follicular lymphoma patients, has shown 75% complete remissions, with a recent update of the study showing that 40% of the patients are still in complete remission after 10 years. Using yttrium-90 ibrutinib tayuxetan, which is the only radioimmunoconjugate licensed in Europe, Scholz and colleagues have recently shown slightly lower CR and progression-free survival rates, yet in a cohort of 59 follicular patients who had strictly defined requirements for treatment according to the criteria of the National Comprehensive Cancer Network and the French GELF group. The report by Illich and colleagues in the article that accompanies this podcast further underlines the role of radioimmunotherapy as first-line treatment of follicular lymphoma, confirming that it can induce significant rates of remission and progression-free survival, which compare well with chemoimmunotherapy, yet causing lower rates of severe infections and avoiding many side effects of chemotherapy, such as nausea and vomiting, cardiovascular and neurotoxicity, alopecia. The authors studied 72 patients with follicular lymphoma in need of treatment using 2 sequential doses of yttrium-90 ibrutinib tayuxetan given 8 to 12 weeks apart and administered 4 preemptive doses of rituximab if bone marrow infiltration by lymphoma exceeded 20%. The fractionated sequential radioimmunotherapy schedule allows to increase the radiation dose from the standard 15 megabecquerel per kilogram to 22 megabecquerel per kilogram, resulting in a CR rate of up to 70% and an improved median progression-free survival of 40 months as compared to the 26 months reported by Scholz and colleagues. Further, the schedule is suitable for patients with a bone marrow infiltration exceeding 25%, which is the upper limit for the licensed application of yttrium-90 ibrutinib tayuxetan, and appears to be effective in patients with bulky lesions, which are poorly targeted by standard dose radioimmunotherapy. Altogether, the report by Illich and colleagues provides further strong evidence that radioimmunotherapy, a highly underused treatment, has significant activity and low toxicity in untreated follicular lymphoma patients. Nevertheless, a few points need critical discussion. First, 13 out of 72 patients received 4 preemptive doses of rituximab prior to radioimmunotherapy, which may have significantly contributed to the improved results of a standard single-dose radioimmunotherapy. Second, although the incidence of severe infections in the protocol was low, duration of neutropenia and thrombocytopenia almost doubled after the second radioimmunotherapy application, making frequent visits to treating physician necessary and requiring platelets transfusion in 14% of the patients. Third, 17 patients received only a single administration of radioimmunotherapy, yet had excellent long-term results, raising the question whether the second dose should be given only to patients failing CR after the first application. How does this paper affect the practice of upfront treatment of follicular lymphoma? Let me first state that my considerations apply only to patients in need of therapy as defined in the paper, so I will not discuss patients with indolent course of the disease, which in my opinion are still best treated by careful watching. This paper confirms that radioimmunotherapy is an attractive treatment for follicular lymphoma. It appears to be as effective as R-CVP or R-CHOP, being maybe inferior to bendamustine and rituximab, but with a better toxicity profile than all chemoimmunotherapy regimens. It is a reasonable choice as first-line therapy, although it must be stressed out that in Europe, negotiation with the health insurance companies is mandatory since the drug is not licensed for upfront treatment. 4 preemptive rituximab applications can make radioimmunotherapy available to those patients with heavy bone marrow infiltration and appear to enhance the overall efficacy of the treatment as compared to standard radioimmunotherapy, which only includes a single rituximab dose. In my opinion, 2 points raise a question on the superiority of the schedule proposed by Dr. Illich over standard single-dose radioimmunotherapy. First, we have very little data on the long-term safety of the increased radiation exposure, particularly considering that a number of patients will need several lines of chemotherapy if disease relapses. A study with more patients and longer follow-up appears mandatory before the schedule can be widely used. Second, the fractionated schedule partially compromises the attractivity of radioimmunotherapy. Standard radioimmunotherapy requires a single visit to the nuclear medicine department, a much looser follow-up due to the shorter and less profound level of neutropenia and thrombocytopenia, and bears a lower risk of infections and bleeding. Fractionated radioimmunotherapy also doubles the cost to the health system. Considering both issues, a substantial increment in efficacy over standard radioimmunotherapy should be demonstrated in a randomized trial in order to justify risks and disadvantages for the patients, as well as the higher cost of fractionated radioimmunotherapy. Let me conclude that we have now 3 published studies demonstrating that radioimmunotherapy is a well-tolerated, effective frontline therapy for patients with follicular lymphoma. 30 to 50% of the patients may not experience sustained remissions, yet their chance of responding to further treatments is not effective. On the other hand, 40 to 50% of patients appear to have long-lasting remission durations of up to several years with just 1 shot of therapy, or 2 in the study by Illich and colleagues. Considering the high median age of the follicular lymphoma population, some of these patients may never require further treatment. For older, frail patients with follicular lymphoma, patients with significant comorbidity, and patients with low compliance or little access to health structures, radioimmunotherapy might well be the best frontline choice. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.